Hi, I'm Dirk van Bavel, orthopaedic surgeon for Melbourne Hip and Knee Group. I also work with Stryker in teaching and training MAKO robotic surgery. And today I'm going to show you the new features of the MAKO 4.0 software, which allows us to look at virtual range of motion and plan to avoid impingement of hip replacements and hence ideally reduce the hip dislocation.
Before looking at functional planning, you should have an idea of basic planning of the cup and stem with the MAKO software. This can be seen on my previous video on MAKO THA planning.
We can see here on the screen that there is a box in the bottom right with standing and sitting numbers, and this is part of the upgrade into MAKO 4.0 that allows us to look at pelvic movement. So we can enter the patient's sacral slope or pelvic tilt. So for this patient, standing is 30 and sitting is 45. And that gives us an idea of the patient's sitting and standing inclination and version of the cup. When we come to sorting out the femoral component, we want to try and match the leg length and offset to a non-diseased hip, but if the hip is diseased, then we need to make a judgment call about what length to put this component into. We can see here that the femoral stem version is only 5, whereas normally I'd like to have it somewhere around about 15 to 20, so let's rotate that around. And this is much higher than the native femoral version of this patient. So let's just stop at 15 and see how that fits. Then this is a short 125 length 44 offset stem, and it's really quite tight. So the blue is the stem and the yellow is the cement mantle, and we're going to struggle to fit this in. This leaves us with an interesting dilemma. We could try a 44 0 125 stem, which is a longer one, and see if that fits. And potentially this is going to be a slightly better fit for this patient. Currently this is now making the hip longer than the pre-op, but shorter than the opposite side. So if we're trying to match the opposite side, we'll raise the stem out a little bit. And we now have matched the length of the opposite side, but our offset is a little bit decreased. So we can increase with a head length. All right, so now we're the same length as the opposite hip and just slightly decreased offset to the opposite hip with the +4 head. Looking at this coronal view, that looks like it's going to be a snug fit. On the sagittal view, we probably need to move the component over a little bit and change the angulation a little bit for a better fit. And on the transverse view, that fits quite snugly the whole way down. So that's my femoral stem now planned. We can then look at the 3D virtual range of motion plan. And this shows the components in place as they are planned, and we can then move the hip into any position we want. So let's start by flexing the hip. 90, 100, 110, 120, 130, 150 degrees. Now patients don't get to this angle, but we can see here that for 150 degrees of pure flexion, there is no impingement between the femur and the pelvis, and no impingement of the components. Now this can be a little bit hard to look at sometimes. I'm going to take that femoral component out of the way, and now we can do the same sort of movements, but with a clearer view of the acetabulum. So what we might do now is try and internally rotate the femur at 90 degrees of flexion and see if it starts to impinge in any place. All right, so we've got to 60 degrees of internal rotation. Now at 65, you get this little red dot which is just appearing, showing some impingement. Now that's a pretty reasonable amount of internal rotation and flexion, so I think I'd be happy with impingement occurring at that point. If you weren't happy, you could change the cup inclination or the cup version to decrease that impingement. So let's dial up a little bit more version. Right. Now there's no impingement at 90 degrees of flexion and 65 of internal rotation. Right. We want to dial up to 70, a bit more femoral version, so a bit more acetabular version, we'll get rid of that impingement. So this allows you to work out what position to have your cup component in to avoid impingement. Now, while we've just looked at sitting, we also need to look at standing and compare that. So we can see now that in standing of only 5 degrees of extension and 15 of external rotation, we've got acetabular impingement. So let's undo some of what we've done and dial back this version and dial back the couple inclination to where we were before. All right. And now we don't have any impingement at 5 degrees of extension and 15 degrees of external rotation. What if we want more external rotation? All right. So here we're getting much more impingement. So what can we do to fix this? Well, we can go back to our femoral component and look at changing the version. So let's change that version back down to 5 degrees, which is closer to the native version for this patient. All right, we can see now that at 5 degrees of extension and 20 of external rotation, there's no impingement. 25, just starting to get a little touch of impingement. So this is much better for a standing stability point of view, but has that affected our sitting? Well, yes. So now we're getting impingement at 60 degrees sitting. So this is a real problem. And this is one of the issues we have that in balancing what to do with certain patients. So we see that both in sitting and standing, there is going to be some impingement within the range that I'm happy for. So we can then look at changing this by changing the articulation to maybe an MDM. All right. And while there is a little bit of impingement now, this is going to be more stable, both in standing and now in sitting, sitting as well as standing.